Do you ever struggle with what to say to your clients, especially the ones with a history of trauma? In today's podcast, I have an enlightening conversation with Dr. Tracey Vogel, who offers strategies to help you listen to your clients and then respond using more relatable, positive language. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome, everybody, to this episode on the Birth Healing Summit podcast, where we have Dr. Tracey Vogel with us today. And we are going to be talking about trauma-informed communication strategies. And Dr. Tracey Vogel is a obstetric anesthesiologist. That's a mouthful, Tracey.
I know.
I have to pause to get it all out. But welcome to the podcast. Thanks so much for being here. So you're an obstetric anesthesiologist in Western Pennsylvania. She's a director of the Allegheny Health Network's perinatal trauma-informed care clinic, which was one of the first in the nation. And she also developed a website called the Empowerment Equation. And that website was developed for both clients and patients and healthcare providers to understand more about trauma-informed care. And so first off, Tracey, we know that we have an understanding of trauma, right? But what is this trauma-informed communication strategies? What do you mean by that?
Well, and I think you feel the same way I do, that trauma awareness, trauma-informed care essentially is using a more holistic approach to how we interact with individuals, treating them with respect, trying to understand them in their cultural context. That's what trauma-informed care really is. And there are some structures to that are defined by the Substance Abuse and Mental Health Services Administration. They have 4 R's, which are things like realize the pervasive nature of trauma in our culture, recognize what it looks like, respond by changing your policies and your practices with the knowledge that you have, and then resist re-traumatization. So it has a structure. But what it doesn't tell us necessarily is, what do you do with that structure in different disciplines? Like trauma-informed care approaches might look a lot different to someone in law, for example, or or the officers on the street, for example, using trauma-informed care principles to de-escalate a situation, or someone in the educational sphere might use them differently. But bringing trauma awareness and trauma-informed care into healthcare is a little, we don't know what to do yet, so to speak. We don't know what this means, although different areas are starting to use it more and more. Looking at it within obstetrics, we have to think about the population that we serve, what kind of trauma they might be coming to delivery with, even pre-existing, what kind of traumas they might experience there while they're delivering their babies. And so our language is going to be similar to others in other disciplines, but I think it's also going to have its own uniqueness to it, given the nature of what we do in obstetrics.
Yeah. And I love, before we hit the record button, I was just like, Tracey, why do we even need this? Like this trauma-informed care really is just about respecting the person in front of us, the person, our client, our patient, but really understanding where they're coming from, right? And that history. And that can be pretty challenging when we're dealing, you were talking earlier in the Birth Healing Summit interview about most OBs only have 7.5 minutes with each client. And that, like, how can you even develop a rapport in 7.5 minutes? I mean,
the timing it makes it very, very difficult. It's one of the barriers. Now, I'm assuming they have a little bit more time on an initial visit, But on a return visit, when it still might be important to bring up certain issues, it's really challenging for my colleagues when they're only given so much time.
Yeah. Yeah. Okay. And let's think about this from, a hospital setting where a person is giving birth. We're not on the clock there. Right? Well, actually the baby is, because it has a baby. We have to get the baby out in a certain time frame, right? But what prevents these OBs and even the nurses from giving this kind of trauma-informed care to begin with?
Great question. So you're asking, like, what's the barrier?
Yes.
Why is, because we know, and now that I've trained and I understand all this, it seems like common sense, right? Why isn't it being used everywhere? It's inexpensive. It has good outcomes. It doesn't require expensive or unique technology to do this. But what is it? What's the core of this? Well, one is there's a lack of education. Right? I thought 10 to 12 years ago, I was always very, I thought, compassionate with my patients. People would send me those that they thought were difficult because I had a nice way with patients. But I found out I had a lot to learn as well. And once I started to get more education, get some training, and not just learning from other people that understood trauma, but also learning from patients and listening, then I realized, oh, okay, there is a different way to do it. So like any other skill, you need training, right? So there hasn't been enough training to come in to teach these providers. Another thing that I think is very interesting about trauma and obstetrics is that as providers, we're not used to sharing control, right? We are trained from the beginning, especially for physicians. We are trained to know everything. We think we know everything, we do everything right, then outcomes will be good. And we don't easily share that control, right? So that's a piece that we have to work on to understand. Like, shared decision making is sharing, and it comes down to sharing control. So that's a little difficult for us, right? That's another barrier.
And I think one of the biggest issues that most pregnant people have is giving up the control of their body as they're in birth.
Yes.
Too, right?
And it's a very vulnerable time. And a lot of the trauma survivors that I work with, I mean, that's at the core of what they need at a subsequent pregnancy or delivery, is a sense of control. It has to be given back to them, or someone who's had childhood maltreatment or intimate partner violence, sexual assault. Control has been taken from them, right? Yes. Just like it can happen in childbirth, and we need to give that back to individuals. So control is another issue as to why it hasn't been rolled out. The third one, I think we already talked about, is time, right? We've got to give people time, but even without time, you can still make certain things happen. You can still be respectful. You can still see things differently. I think another barrier is that we all carry our own traumas. Everybody on the obstetric floor has experienced trauma in some way in the workplace. They just have. And if, let's say you worked there for 10 years and you say you haven't experienced trauma, most likely you've had some taste of it. And maybe you have your own trauma from outside the hospital too. So sitting and perhaps maybe opening the doors to why someone else feels the way they do might be difficult and might trigger them themselves. Yes. And maybe they feel, and I would say, it's not really productive to feel this way, but if they feel that they can emotionally shut off from patients, then they themselves won't be harmed as much. But we now know that doing that leads to more burnout, earlier, job dissatisfaction, less engagement, and burnout. So that's maybe not the right way either. But I think those are all some of the barriers to having trauma-informed care everywhere, or this, what we call, this respectful care.
Yes. Yeah. Wow. Those are big ones. Those are big barriers. Yeah. I think the biggest one being the trauma within ourselves that we may not have even acknowledged.
That's true. I mean, there are a lot of
Right?
trauma survivors that come to obstetrics who have not disclosed, have not had their trauma addressed.
Yeah.
They've not had any kind of treatment at all, and they don't even know what's about to come at them with labor and delivery, right? And those are the ones that we love to see get intervention and have prehabilitation, which is a word that I love, where why not work with pelvic floor physical therapists before they get to labor? Why not have nutritionists talk to them? Why not have the doulas work with them?
And the
Why
mental health practitioner.
and mental health,
right?
yes.
Yeah.
I
Absolutely.
even do it was virtual for a long time, virtual operating room tours. Labor room tours are pretty easy, I think, to get at most hospitals.
Yeah.
But to be able to see what an operating room might look like, I do that routinely. And now I've started taking people into the operating rooms, and with great success with that. They have felt that they were prepared, right? Let's get them used to the environment, not just their bodies, the teams,
Right.
but the environments as well.
Do you do that with every birthing person, or just those that you know are going to have a cesarean? Because some births end up there by emergency route only. So I'm curious, do you take everybody back there, or just those that you know are going to have a cesarean birth?
For right now, those patients that come through my clinic, I offer it to all of them. If they would need that, if they would think it's useful, I'd be happy to do either of them, virtual or a real tour. Yeah. I have some colleagues in Colorado, and I was so delighted to hear that they've already done a research project, where they take their high-risk individuals, meaning those that they know are going to have a C-section, ahead of time, walk them through, prepare them for everything. And now we're going to have the data to show how impactful it was on their anxiety scores before and after. Because we all know that it makes a difference. It helps these individuals prepare for the birth, have less anxiety, maybe even get through pregnancy a little bit easier. But we're not doing it routinely. And I think I'm going to say old fashioned, I hate that word, but older thought processes where we don't want to scare individuals. Well, if a third of our individuals are ending up there, why not prepare them and make that environment less terrifying?
Absolutely. And in another interview I did in the summit, we talked about pain science and how fear is one of the biggest contributing factors to increased pain, the feeling of pain. And what I see in my practice all the time is that the people who are like, oh, I'm not going to have a cesarean. I don't want a cesarean. I'm not going to have a cesarean, are the ones that usually end up having the cesareans. And so I really inform all my moms is like, face your fears, talk about your fears around this upcoming birth, because it's the fears that you don't address that might end up playing out the most in your birth. Right. And so that, talking about fear there, what can we do? Let's go back to the topic we were talking about here, is our communication strategies. What can we do as providers? What do we need to think about in our communication with clients that have had trauma? So we've talked a little bit, we talked in the summit interview about the red flags that we need to be aware of for clients that we're working with that may have potential trauma in their history. Can you just remind us some of those?
Well, some of the pre-existing trauma can come out as mental health disorders, anxiety, depression. They might even come in with a history of PTSD, substance use disorders, addictive behaviors, or behavioral behaviors behavioral disorders like eating disorders. We might see sexual promiscuity, those kinds of things. But then you're also going to see some physical manifestations as well, that we now know trauma can live in the body with chronic pain, chronic illnesses. And then we talked about the triggering that can happen when they come to labor and delivery, how their behaviors can change a little bit with refusal of care or hostility, or even tightening their body, their stress response to cervical exams, for example. So those are a few.
Absolutely. And when those muscles don't want to release, I tell my practitioners we should never be forcing them to release, because there's a reason they're tight in the first place. And part of our job should be, as physical therapists, as body workers, is to help our clients understand and try to get to that root cause of that tightness in the first place. And it may be trauma related. It may be, their history coming out through their tissues. So what do we need? So now that we're aware of, people that might be presenting with trauma, what are some of the communication strategies that we should be aware of as providers?
Well, one of the things that I like to teach is something called the L.I.V.E.S mnemonic. Like, we are saving lives, L-I-V-E-S. And this came out of a study that looked at providers or practitioners' responses to those who were survivors of intimate partner violence. And so it stands for, L is listen without judgment. The I is to inquire. The V is validate. The E is ensure safety. And the S is support follow-up. So even if we talked about the first three, those are core elements regardless of the setting. So learning how to listen, we all think we're probably good at listening, but have you ever really just sat and not said anything for 20 minutes and let someone else talk? So the key here is not to interrupt. Let someone tell their story without judging them, without trying to fix it, without trying to make it better. Just listen, because a lot of individuals never have a chance to tell their story. Right? Inquiring is inquire only about what you need to know, right, to get them a safer experience or a more positive birth experience. We don't need to know all the details of what happened when they were 5, for example.
Yes,
it's enough to know if they told you they had trauma or something happened. Okay, let's make those assumptions, right? That's okay. So you come from trauma. Maybe you could say to them, do you feel comfortable sharing with me things that make you feel safe? Right? Inquiring about safety. What do they trust? Who do they trust? Is there someone in their life that's going to be there when they deliver? Those kinds of questions. And asking them what their ideal birth experience might look like, right? And how could we possibly get them there? The V is validation. And that goes along with listening too. It's listening and then realizing and letting them know that you hear them, right? Boy, that sounded like a really awful experience, what you just went through. I'm really saddened that was your experience. Something to let them know that, yeah, and it's okay to say that your pregnancy was awful or your delivery was awful, because our society would make you think that everything's all joyous in the land of obstetrics. And it isn't necessarily. We'd love it to be, but it's not necessarily that. And so many individuals don't talk about traumatic births because there's still stigma, or they think that they shouldn't. They should be happy.
Yeah.
So validation is really key. And then ensure safety. That also is playing into what can we do to create a safe space for them? Safety with what kind of procedures are we not doing with them? Are we entering the room where they can see us? Are we knocking before we come into the room? Right? Maybe they need in their space some smells that are positive for them. Like, I have people bring essential oils all the time. I wish we could burn candles, but we can't do that in the hospital. So maybe at a home birth you could, but
yeah.
But smell, I'm a big smell person. So any kind of smells they want to bring in, music, pictures, keeping the lighting low might help for individuals. Minimizing traffic in and out of the room so that patients are not overwhelmed, right?
Yeah.
You may work in an environment where you always have a student, and maybe this is a person that you say, the student is going to sit outside for now. Maybe you can meet them later, but we're just going to keep them hands off for the moment.
Yeah.
It's just, I'm all about teaching. I've been a teacher for my whole career, and I love educating residents, students. But there are times when I do believe that having a student might not be the best thing for an individual. Sometimes the student is the best thing, and that person is there at their side for the whole delivery, and that's fantastic. But you have to take, each case is a little bit different. So creating that environmental space for people to feel safe. Maybe keeping a door open if you're in an exam room initially, so that they know they can get out. We don't think about that all the time, but I think it's important that you ask them, is it okay to close the door? Do you want to wear your own gown? Do you not want to take your clothes off today? That's okay. First time, maybe not.
Yep. Yeah. And we shouldn't assume anything, right? We need to ask. And sometimes I find people who have experienced trauma aren't always aware of what they want. They're not as connected to their body or, to what's going on, especially if they had an injury or an event with a male and it's a male provider. I know there's a lot of people that don't want male providers anymore. How do we help these clients be able to find that sense within themselves to know what they want, to be able to speak it, to help, right? To help them to be able to, so that we can help them, right? Because if they don't know what they want.
I think there are two things that can help here. One is for us to try to normalize things so that they know what their choices are, right? If I think someone has a history of trauma, for example, and they're sick, and we know they have, let's say, preeclampsia, very ill, their baby is ill too, and they are not agreeing to anything that would promote a safe and healthy delivery, let's say. If I need to tell her about the operating room and I have a feeling like there's some trauma here, I could normalize and say, well, the operating room is terrifying for most people. And some of the things I do to help all my patients is we don't have any arm straps. There are no arm straps. We don't use oxygen masks unless you want it or it's indicated. I usually have them bring their partners back to the operating. And then when a patient says, oh, you can do that, then you realize, okay. So now we've opened the doors to having more discussions about that. So normalization and kind of saying, well, here's what I usually offer everybody, kind of thing. It might make people feel a little safer to say, oh yeah, that sounds nice. The other thing is and I've taken Penny Simkin, who is wonderful. Someday I'd love to meet her. Hopefully she's out there listening somewhere. She has written a book called When Survivors Give Birth, but she has some great worksheets in the back that can be downloaded. I've taken those and added to them and added some anesthesia things to it. But those worksheets could be given literally to every patient and say, once you look through everything that happens through the course of labor and delivery, and including a C-section, what's your personal meaning? Does any of this scare you? Does anything come to mind? And then what you want to see happen. And so then it's a starting point for a conversation. So maybe that's one way for an individual to say, oh, never thought about that. Wearing my gown. Oh, they have straps on the beds. I didn't even know they had straps. Okay. So, we have to tell them what's coming in order to know what they can choose or how they think about things. So those are a couple different ways. I think too, and we're promoting this a lot where we are, is having a doula as that extra person to be their voice in a very vulnerable time. When you're in pain and in the throes of it all, you need that person, and your significant other is doing a different job, right? And so they might not be able to speak up, but I think having that would give them a voice as well.
Absolutely. Do you have any advice for those doulas to help them to be better able to support their clients in either the labor room or even in the, cesarean if they're having a cesarean? As an anesthesiologist, what would you want to tell doulas in supporting their moms during that surgical procedure?
I think for them, if they notice anything that patient is experiencing that we're not picking up, let's say there's a complication in the operating room, and I have to address certain other things. And if she wants to tell me, hey, I think she's starting to get really anxious right now, because the doula might know her, right, better than the
Yes, yeah,
anesthesiologist.
yes.
Maybe communicating that to the anesthesia team would be important. I think the more that we're getting this word out about trauma and how things can be perceived in the operating room, providers are becoming more open and welcome to this concept of trauma-informed care, and working as a team to making sure that we're taking care of the psychological health of our moms as well in the operating room. So I would say, picking up on anything, reminding people that, well, this is what she'd really like. She really wanted for dad to trim the cord. Just putting that out as a reminder might be very helpful, right?
Awesome. Yeah.
Yeah.
Yeah. So important. Oh,
Mhm.
that's great. Cool. So is there anything else that we need to be aware of with our communication strategies when we're dealing with a client that may be experienced or have had experienced trauma in their past?
I would say, think about the spoken words that we use. We've gotten in a habit of using this jargon, which comes with every profession, right? We all have our way of communicating with each other, but there's some words that we use that can be really harmful for trauma survivors. One is when we say failure to progress. Ever think about that? Failure is everywhere. A lot of our trauma survivors have a lower sense of self-efficacy or self-worth, even due to chronic traumatic stress and maybe re-traumatization throughout their lifetime. The last word they want to hear is failure, because they're already putting that on themselves. So why do we have that word in there? How about if we said poor maternal effort? That's out there too. We went to the operating room because poor maternal effort. And I say, when I teach this, well, if we've deprived someone of food for 24 hours, they haven't slept in 48, they've been pushing for 5, and now we're going to say we're going to the operating room for poor maternal effort. Imagine like how devastating that could be to someone that hears those words, right? Another word that comes to mind, something when we say, oh, they're difficult. That's a difficult patient in that room. To me, all that means is we don't understand them, right? We don't understand where they're coming from. And when they get dubbed as a difficult patient or a non-compliant patient, another one, like we're blaming them, it can be psychologically damaging for those individuals. So we need to step back and think about the language that we're using with everyone, and not only how we speak it, but how we write it as well. I think too, in certain circumstances, saying nothing at all is better than some of the things we do say. Like often we know someone has gone through something difficult and we try to fix it, and we say, oh, well, you should be happy you had a healthy baby. Right? How many times we've heard that, and now we realize just how dismissive that is to our birthing people. Yes, they can be joyous. It can be a joyous occasion. They can be grateful. Sure, they are, right? They've done everything right for 10 months, and they've sacrificed and had this incredible baby. But they are also allowed, and I tell you, it's highly recommended for you to feel angry, frustrated, sad, depressed, whatever it is, at the same time. It's important, right? So sometimes for us as providers, we just need to let them know that you have permission to be angry or whatever it is you want to feel. It's okay. And sometimes it's okay for us just to sit there and say, I really don't know what to say right now, but I'm glad that you shared this, and you are not going to be alone. We're going to get you whatever support you need to get through this, right? So that's the type of language that's much more trauma aware and supportive than some of the other things we say. And then the last thing I want to say is, trauma-informed care is also about strength-based approaches. This is like a new addition to it. So think of how long we've put blame on individuals for not following the care or for using substances, and that doesn't really help. It's never helped. We're not doing any better with our maternal mortality rates. So my philosophy is, and so is trauma-informed care, they're putting out, the CDC says, let's do strength-based approach. Let's tell them what they're doing right. and not focus on
Yes.
what they're doing wrong. And that we might get to be able to build better trust, more engagement in healthcare, and then better outcomes from that standpoint too. So our language is so important
Absolutely.
in our interactions.
Absolutely. Oh, that's so great to hear. And I love that new approach, focusing in on the strengths.
Right.
Duh. kind of takes us back to the very beginning of this, and it's like, why does this even need to be a thing? But like you said, you've never been trained in this awareness, in knowing what to look for, what people have been through and how that shows up in their body, and how to talk to them. So I so appreciate this enlightening conversation here. We're all about having meaningful conversations here on this podcast. And I would have to say, Tracey, this is one of the most meaningful ones in regards to caring for our clients that may be dealing with trauma. And really, I love that L.I.V.E.S. Just real quick, L.I.V.E.S is listening, in investigating, inquiring,
Validation,
validation, and
ensure safety,
and
support follow-up.
Support follow-up. Yes. Awesome. So let's keep those in mind, and let's look for our clients' strengths in everything that's happened to them and in their labor progress. And don't what is it? We all, even in job interviews, you want to focus in on the strengths, not the weaknesses, everybody.
True. Yeah.
Right? Oh my goodness, this is great. So everybody, thank you, Tracey, for sharing what you did. And I want to encourage everyone to check out your website, the Empowerment Equation, so that we can learn more. And tell us a little bit about that website.
So I created it several years ago just as a starting point, because I just had to do something. This was before my clinic came into being. And it really is a site meant for individuals to tell their stories. And I wanted to teach providers through narratives. That's the goal of it. But it does have resources on there. But the testimonials that I have are handwritten by the patients. And it also has commentary on what providers could have picked up on, how could we have done this differently, what are some resources that they could read to help them if they're working with patients like this with trauma. And it's also a way for individuals to get in touch with me who have gone through some difficult times and need some help in navigating childbirth at subsequent time. It's like my clinic, but available to others across
anyone, anywhere. And Tracey, do you do Skype sessions or Zoom sessions with anybody anywhere, or are you just more local in-person appointments?
So within Allegheny Health Network and the clinic, I do primarily virtual, but I do offer in person. So I have those that definitely want to meet in person. And so that's part of the Allegheny Health Network. That's that job. But for those that I have met through my website, I do that just through Zoom. Nice. If anybody really wants to talk, or email, or whatever platform, FaceTime, done that too.
Okay, awesome. Well, great. Well, anybody listening, if you feel like you need that support, please reach out, and we'll put your website in the show notes. Okay.
All right. Sounds great.
Thank you so much for what you shared with us today. And everybody, please keep in mind L.I.V.E.S and what that represents, and look for the strengths in our clients. All right. Thank you. And we will all see you on the next podcast. And here's to smoother births and faster recoveries. Take care, everybody. Bye-bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.